I'm Julia Caton. I am an internal medicine doctor. I'm a hospitalist, and I'm also a medical educator, which has been a part of my career since the beginning. And I work mostly with medical students, both clerkship students and preclinical students, but I also spend a lot of my clinical time with residents, so I have sort of a foot in all of the worlds.
For those third and fourth year medical students that are doing their clerkships, what would you say to a third year medical student who's about to start their medicine clerkship? I know it can be intimidating because you're thinking, I have to know everything about medicine, and that's the only way that I'm going to impress my attending. So what advice do you have for just a third year going to start their rotation?
Yeah, well, I guess first I would say that I totally can empathize with the fact that it feels scary to start medicine because it's just such a big thing. I remember when I was going to start my medicine clerkship, it was my first clerkship in the whole clerkship cycle, and I was absolutely terrified for the same reason. So I understand what it feels like. But what I would say, a few things. First is that nobody is expecting you to show up on day one of medicine knowing all of internal medicine. Mm-hmm. If you did, you could graduate or, skip residency. No one is expecting that because the whole purpose of the medicine clerkship is to learn medicine. That's what you're here for, and we know and expect that. So I think the first step is to just take a little bit of the pressure off of yourself. And then the second thing I would say is that even though medicine feels really vast and really, really big, I think it can be helpful to think in terms of buckets, because when you start bucketing the things we see in internal medicine, it becomes smaller and more manageable. So if you think about the really common things that we see, acute kidney injury, you're going to see that multiple times over your clerkship. Various types of infections causing sepsis, so you're going to see sepsis over and over and over again, and in a few key buckets: infections in the lung, infections in the genitourinary system, so GI related infections. You're going to see GI bleeds. There are sort of a bunch of big buckets that you're going to see over and over and over again. And so familiarizing yourself with what are some of those big buckets, and then anytime you see or hear about a patient on rounds that has one of those conditions, thinking to yourself, okay, which bucket do I put this person into? Mm-hmm. And how is this the same or the different than the last time that we saw AKI? Oh, we talked about AKI with a patient on rounds 30 minutes ago, and we're talking about this patient a little bit differently. What are the similarities and the differences? And hopefully that'll start to make medicine feel a little bit clearer.
Got it. And so you mentioned that there's usual diagnoses that you see, and so you're probably exposed to those during your preclinical years, right? Because that's what most of the content is. But I know for pediatrics, there's also pocketbooks that you can throw in your white coat that go over the most common things that you see, so that, if you notice that a patient is being diagnosed with that, or you're going to have a patient on rounds, you can just go to that chapter and kind of refresh. So is there an internal medicine equivalent? Is there something you could throw in a white coat, an app on your phone, some type of resource that's attending approved that students could look to?
Yeah, that's a really good question. I think medicine is big, so there's not one thing. There are a few things that I like. I'm a real big podcast learner, and so even myself, if I know that there's going to be something that's tricky that I'm going to teach about on rounds that day, I'll find a podcast episode to listen to on my way into work so that I feel really fresh when I get to rounds and I'm going to teach about that. So there are a couple of podcasts that I think are great for clerkship level students that are on their internal medicine rotation. The first is a podcast called Run the List, which is geared specifically towards clerkship students, and I think that's a really nice reference, and I know students have told me that they really appreciate that one. Okay. Some other podcasts that I think are really great places to look are Curbsider's Internal Medicine. There's a podcast called Core IM, which covers a lot of internal medicine related topics and content and does a really nice job, and some of their episodes are shorter too. And then there's a podcast and sort of platform called Clinical Problem Solvers, which has some really nice podcasts that go over diagnostic schemas for common internal medicine problems. And all of their diagnostic schemas are also online. And I think that is a great sort of visual reference for learners to look to. And they have, for things that come up all the time in internal medicine, like hyponatremia or syncope or chest pain, these things that we see all the time. And you need to have sort of a diagnostic schema, a way of thinking through that problem and figuring out how to get from one diagnostic bucket to another, and their schemas are really nice.
Oh, great. Okay. And so let's say that you have a student who is prepared to discuss or at least bring something to the table or stay in line with the conversation when you're discussing their patients on rounds or the team's patients. But that's kind of basic, right? Like every student is kind of anticipating that they're going to be prepared to discuss the content that they see on rounds. What can a medical student do to stand out and impress you as they're attending?
Yeah, good question. I think a couple of things, but I think the principle, the North Star that a student should have is they want to be the person on the team that knows their patient better than anybody else, and in every sense of that word. So this is what I often tell the students when they start on my team, is that they want to be the person that knows their patient the best. That means knows them personally the best, knows about their life, knows about their support system, knows about their background, knows them medically the best, has looked back through all of their old clinic notes, their last few admissions to understand what has gone on in their medical history, knows their medication list, knows what their barriers to discharge might be, and knows everything that's happening for them in the hospital, which means looking at, speaking to the nurse every day, looking at all the consultant's notes for that patient, making sure that you're really familiar with all the new data for that patient as it comes in. And if you can really orient yourself towards, I'm going to be the person on the team that knows my patient the best, and can advocate for them from that perspective, then I think that you will both get the most out of every patient that you see and be the most sort of value to the team and the value to that patient, most importantly.
Yeah. So I guess if I had to make you give an example, right, of two students rotating with you, they're both third years. One is, what is the bare minimum that you would expect any third year to be able to do if they were presenting a patient to you? And what is something that an impressive third year medical student does on top of that to stand out? Could you give an example there?
Yeah, sure. So I think that I think it's sometimes helpful to think in terms of that RHIME framework, that reporter, interpreter, manager, expert, in terms of thinking about sort of where students fall along the continuum as they develop their skills in the clerkship year. So I think of sort of the first student that you described as being more in that reporter level, maybe starting to get towards interpreter. So they're able to effectively collect all of the data for their patient on pre-rounds. They're able to see their patient in the morning and gather some history and do some physical exam, and then come to rounds and in a clear and organized way present all of that information. But they might not have as robust differential diagnosis or an assessment for any active problem on their list, and they probably don't yet have a really sort of granular idea of what the management plan for that patient is going to be that day.
Okay.
And then what I would say is that as students sort of move up develop their skills a little bit more, then they're able to build in more of that interpreter perspective and start to put in some pieces of the manager role. So that means that they're coming to rounds and they're presenting their patient in a way that's organized and that's complete and that's efficient, but that also when they get to that assessment statement, I can tell, and even before that in terms of the data that they're picking to present, in terms of what's important on the physical exam that we're tracking every day, what labs are the important labs that we want to pay attention to, and then when they present that assessment, I know that they have a clear sense of sort of what are the key issues, what is the most important issue for the day for that patient, which may not be the same as it was the day before. What do they think is going on? What are some alternatives that they considered, and why do they think that they're less likely? And then starting to really build that granular, specific management plan. So not just, I think this patient needs antibiotics, but what antibiotics do they need? What's the duration of those antibiotics going to be? What's the dose? Are they oral or are they IV? And how does that impact their care plan?
Okay, great. And so also alternatively, I think students are also nervous about how do I stand out, but how do I not stand out in a negative way? So besides the usual oh, I can't answer the questions or I can't discuss this patient because I'm not prepared, is there anything that students do that is a red flag in internal medicine that would make them stand out in a bad way that they should avoid doing?
Yeah, I think that the most important is just being mindful of prioritizing being present on your team and being involved in the clinical care. So I think that the biggest red flag probably that we see on internal medicine is when students feel understandably pressures getting pulled in other directions, like to study for the shelf, and they disappear in the afternoons. And that's something I'd want to avoid. I think that trying to be present on the team and learning from the clinical work that's going on around you and learning from the patients on the team, spending time with your patients, getting to know them, getting to know their history, that I think is the best synergy of like value to the student and value to the team.
Okay, great. And this might be a little bit more nuanced and a person-to-person answer, but what do you have to do, like what advice do you have for the student who's intimidated by long rounds and staying engaged for essentially the morning?
Yeah, that's totally fair. I know that long rounds are not for everyone. As a hospitalist, I love long rounds.
Yeah,
Just kidding.
from an ER doctor asking a hospitalist, how could a student like demonstrate engagement?
100%. So one thing that I would say is that I think it is hard to stay actively engaged when the team is talking about patients that are not your patients. So finding ways to keep yourself like sort of knowing what's going on with the patients that are being discussed. So whether that's like printing out a list before rounds that has information about all of the patients, if you're sitting at a device during rounds, like with the electronic medical record open, following along, trying to know a little bit about all of the patients on the team, just in terms of like what is their one-liner, what are they in the hospital for, what are the things that we're sort of discussing for those patients on a day-to-day basis, so that you can really follow along with the discussion on rounds. And then sort of like I mentioned earlier, like looking for opportunities to get engaged on medical problems that you are seeing on the patients on your own, that you're following. So whether that's an acute kidney injury, or 2 different patients that have a urinary tract infection, or 2 patients with abnormalities in their liver function tests, looking for those other patients that you're not following but that have similar issues to your patient, to try to better refine your understanding of what's going on with your own patient. Keeping a running list of things that come up on rounds that you want to do some self-directed learning around, that you don't know as well, or that you weren't sure what that term was, or whatever it is. Keeping a list for yourself. And I think depending on the team dynamic and what's going on the team that day, like asking questions. I think it's great when we have students on our team and they're asking questions and pushing us to explain our thinking, or to really clarify some of the things that we're talking about on rounds. And I also love having learners on the team, because sometimes they're closer to the basic science than we are. And so sometimes I'll turn to the learner on the team and I'll say, like, I know that we use this antibiotic and not this antibiotic, but like, I'm not sure what the reason is. Like, do you remember from your microbiology course, like what is the difference here? And a lot of times, like, it's not to put someone on the spot, but it's more to engage them and to help us learn from the clerkship student on the team.
Yeah. There's so much to learn from that initial exposure to internal medicine. So what do you think a clerkship in internal medicine teaches medical students that you wish every doctor could take away?
A really good question. I mean, it's so foundational, right? And I think for that reason, it's also a really great clerkship, because I think it helps clerkship students learn how to be a clerkship student. I think that to me, the biggest thing is communication, and being that translator from everything that's going on in a patient's care in the hospital to the patient and their family. Because we are often the person on the front line that's explaining to the patient why the consultant made whatever recommendation they made, or why it is that the surgery team saw them and then felt that this was the appropriate course of action. And so developing those communication skills, I think, will serve students wherever they go. And I often tell the clerkship students on my team that if you're looking for ways to get involved in the care of your patient, that the best tasks to look for are any task that involves communication with another human being. So whether that is talking to the patient, talking to the family, calling their outpatient provider to get some collateral information, talking to a consultant, talking to a member of the interprofessional team, like the physical therapist or the dietitian, because for a few reasons. The first is that I think it's a great way to get actively engaged at the level where the student is at. The second is that communicating about your patient to another person requires you to develop a deep understanding of like what is going on with that patient at this moment. And then 3, to translate what you know to that audience. And I think that translating what you know to the appropriate audience is a skill that if students can really hone on their medicine clerkship, it will serve them wherever they go.
Yeah, definitely. So you've obviously given a lot of really great advice for our clerkship students. What's the best piece of advice you got during your training?
So one piece of advice that I got right before I started my clerkships from an attending that I think about all the time is, this attending told me, like, you're going to go to your clerkships, and one of the amazing things about being in the clinical environment is that you're going to have the opportunity to observe so many human interactions. You're going to watch providers, residents, attendings, communicating with one another, communicating with patients, communicating with family members, and you're going to see lots of incredible examples. And you're also probably going to see some examples of communication or interpersonal interactions that don't go so well. And having the opportunity to see all of those is so valuable if you are paying really close attention, because someday you're going to be an independent practitioner and you're going to have to figure out, what is my style? How do I handle situations? What is the best, sort of like, how do I show up at work every day? And incorporating both the amazing examples that you see, and then also trying to figure out, okay, like, what didn't go so well in that interaction, and how would I have done that differently? And like, how will I show up at work that's like a little bit different to make things go a different way, I think is really an amazing opportunity that clerkship students have.
Yeah, definitely. If you had to go back in time and do your third year internal medicine rotation over again, with knowing what you do now, would you do everything the same, or would you do anything different?
I think that the thing that I would do differently is I would be less shy or nervous about asking for feedback. I'd probably try to elicit more feedback than I did, which would mean, like, something I tell the learners on the team is, like, it's always really appropriate, I think, after that first time that you present on rounds in the beginning of a clerkship or when the team switches over, to just find a moment when the team is not, like, in the middle of running a code, or like a moment of downtime, and say, like, hey, how did that presentation go? Was that kind of what you wanted? Should I do anything a little bit differently? And I didn't do enough of that when I was a clerkship student, so I would do that differently. And then to answer a slightly different question, which is, what advice would I give to a clerkship student who is doing their internal medicine clerkship but is not going into medicine? Or what would I give to myself doing all the other clerkships? Is, like, remember that if you're not going into this specialty, this is your chance to see this specialty. And you're going to want to be a well-rounded physician who has some understanding of what goes on, for me, in surgery, and what goes on in obstetrics, and what goes on in pediatrics, both in order to treat my patients, and then also just to, like, because I am the family member that people come to, the friend that people come to, I am a parent, and it's helpful to know about pediatrics. And I don't know that I had that mindset when I was going through all of the clerkships for the specialties that I knew that I wasn't going into, that, like, this is your one chance, so extract what you can.
Yeah, definitely. Awesome. I think that's all the questions I have.
Great. Thank you so much for having me. This was a lot of fun.
Yeah, I had fun. Thanks, Julia.
Yeah.